good time so far. So this afternoon we'll be having a discussion on diabetes mellitus in clinical practice, and we'll be taking some case reviews just to highlight some learning points that we can all learn from.
Okay. Good afternoon, everyone. We'll start with our case one, and after this, these are the learning points we hope to take home after reviewing the case one. So we have, just to say, these cases are real life cases, but the names are hypothetical ones. So Miss Ugo, a 52-year-old trader who went to the hospital because of myalgia, chills, and headaches of 3 days duration. She was given paracetamol for 2 days that only provided intermittent relief. So she was tested positive for malaria, and her fasting blood glucose was 138 milligrams per DL. She was then commenced on malaria treatment and was commenced on metformin and glimepiride. Her condition improved and she felt better. So based on what we've said so far, what do you think, which of the statements on the screen do you think was correct or is correct? Sorry.
So we have 5 options here. Diagnosis has been established, the testing was appropriate, medications were appropriate, there's a low risk of hypoglycemia, and all of the above. So there's a poll.
Poll, if you can just go to the poll. Okay. Sorry. Yeah. So let's get our polls in. Let's get our answers in.
Is it coming up? Yes, we'll leave it there.
Okay.
Okay, so what do we think is the most correct answer in this case? So option A, diagnosis has been established. Option B, the testing was appropriate. Option C, medications were appropriate. Option D, hypoglycemia risk is insignificant here. And then option E, option 5, all of the above. Any thoughts from anybody? Anybody interested in trying to attempt the question can raise the hand until I get it pulled up. Thank you. Who wants to answer? Who wants to try? I think it's a very short case scenario.
They didn't see the case.
Okay, do you want to go?
You want to see the case again? Okay, I'll just go back.
Okay, so we have this patient here. That means we didn't concentrate on the first slide.
A 50-year-old trader that went to the hospital because of malaria, chills, and headaches of 3 days duration, for which she was given paracetamol.
Okay, so just scroll to the poll now.
So, this is the poll.
Next.
So, our answers.
Let's leave it there.
Okay.
Okay, I think we just have to go on. So it's coming on. That's great. Okay, so let's try. Let's attempt. Let's engage the poll, please.
Okay.
Let's engage the poll. Let's engage the poll. Just 10 people so far. There are tons of us in here. Okay, so she came to the hospital with symptoms that looks like symptoms of malaria, and she indeed tested positive for malaria. But our fasting blood glucose was 138 milligrams per DL. The threshold for diagnosis is 126 milligrams per DL. So that's clearly above the threshold. And then she was treated for malaria and then commenced on 2 anti-diabetic medications. Okay, so thank you for attempting. So the largest answer says that the testing was appropriate in this scenario, which is great. And then the next most popular answer says that the diagnosis has been established.
Okay.
Okay, so
Okay.
thank you
Yes.
very much for attempting the question. I think over the course of the presentation, we'll be able to decipher what. So next slide.
Okay. So a week later, her husband noticed she was unresponsive as he tried to wake her up from a prolonged afternoon nap. She was then rushed to the hospital, and her ACS on presentation was 11/15 with an RBG of 2.4 millimole per liter. 50% dextrose water was administered, and she gradually regained consciousness. Her husband realized she could have died, and she was very angry. So, what are your thoughts?
Okay, so I think this case scenario, this is a real life case, okay, and I think there are many things we can learn from this case. I want to believe that we all have our thoughts about this case, about what the questions posed to us initially. And yes, it's important to screen for type 2 diabetes. We should not wait for symptoms before we screen for diabetes. If we wait for symptoms before we screen, we'll have a lot of complications in our hands. So it is good to utilize opportunistic screening. So if you have a patient that comes to your hospital for whatever, and you ask the patient, particularly once the patient has some factors in which we will want to screen, we'll talk about that on the next slide. So we should screen for that. And of course, we should be alert to the, is it echoing? We should be alert to the symptoms of diabetes. That's the common symptoms of diabetes: fatigue, polyuria, polyphagia, weight loss, neuropathic symptoms in the extremities, blood vision, or someone is just sick and then the recovery is quite slow. Anytime we see any of this, we should, so that's like symptomatic. But people can also be asymptomatic. And these are the people in which you want to screen, even if they don't have any symptom. So a 42-year-old man comes to your clinic with back pain. Part of your general question, have you been diagnosed with diabetes before? Have you had a sugar test before? If you say they've not been checked before, you should advise them to check. So those are opportunistic screening. And then if you have any of all these other risk factors there, family history, hypertension, dyslipidemia, previous history that suggests GDM, obesity or overweight, which is quite common, sedentary lifestyle, people on medications that are known to be able to induce diabetes, that's your diuretic, steroids, etc. And of course, previous history of any abnormal glucose test in the past, or if you have a patient that has PCOD. So those kind of patients we should take. So in this case scenario that we described earlier, it was appropriate to check for diabetes in that scenario. So that's screening. Okay, but we should understand this criteria for diagnosing diabetes mellitus. And I think that's one of the questions that was posed by the poll that we asked for. So now these are the criteria, but like they always say, the devil is in the detail. The devil is in the detail, okay? And the third point here says that in the absence of unequivocal hyperglycemia, that the diagnosis does require 2 abnormal tests, okay? So if you just have a mild elevation by 138, yeah, a person could have diabetes, but it's probably, you probably should, okay? So you probably should check on another day, okay? Either you check on another day, which is preferable, but beyond that, you should also get an A1C as well. And I'm happy that A1C is quite widely available now. Someone just presented about the Clover A1C machine as well. So check another day, particularly if the levels are not gross. Now, the one that is unequivocal is one that is markedly elevated. Maybe you're getting like 160, 170 for a fasting glucose. That is not debatable. But even still with that, I would suggest strongly that you get an A1C to back it up. That makes your diagnosis more robust, and it will make your treatment initiation to be more precise, okay? So you're less likely to overtreat or to undertreat, and we are less likely to send people to early graves by causing iatrogenic hypoglycemia. So why do we need an A1C? It helps you to confirm the diagnosis. Now, the drawback of telling a patient to come on another day to confirm your test is that a good fraction of them will disappear. That's the truth. They will just forget, okay? And that means you've lost them to follow up. But if you can get an A1C on that same day, and it does confirm that the person is within this range, and we should not forget that the A1C reflects sustained hyperglycemia. Why? Because it takes 3 months for the A1C to reflect. So it reflects the level of glycemia over the preceding 3 months. And of course, it gives you a baseline. All the studies that are done for diabetes management, all are targeted towards A1C. So because every fasting blood glucose can vary quite widely from day to day, okay? But that woman that got 138 on that day, you don't know whether the day before it was 99 or 104. or 160. You really don't know. But A1C averages that out over the last 3 months, okay? And it can guide our treatment initiation and escalation. Now, we have an algorithm inside our booklet, which we adopted, okay? But we should know that the algorithms from which this was adopted was actually based purely on A1C. But we also included glucose ranges there just to give guidance, particularly for practices that don't have A1C readily available, okay? And if you follow this algorithm for this patient we talked about, first of all, the FBGC was less than 140. It was 138. And that means this patient is a good candidate for just lifestyle treatment only, okay? Now, you can have some patients that are at 138, and maybe the A1C is greater than 7%. Then you probably should consider the patient for medications. And even in that case, if you indeed needed to use medication, you probably should be considering monotherapy rather than dual therapy, okay? And as I said, the A1C is actually much more accurate in guiding that rather than your glucose readings alone. And here we did put that we're talking about average fasting blood glucose. So it assumes that you have checked it on more than one occasion. Just testing someone's sugar at one occasion, grabbing the person and putting the patient on anti-diabetic medications is quite inappropriate. Again, except if the level of hyperglycemia is quite gross, okay? Some patients who qualify for dual therapy invariably, okay? And in that case, typically the A1C exceeds 8 or 9%. Fasting will probably exceed 160 milligrams per DL. Now, don't forget that diabetes is a state of chronic hyperglycemia. And in the absence of hyperglycemic crisis or emergencies, you are not actually under any obligation to bring down the glucose readings rapidly. Not at all. You can take your time in getting it down gradually. And that means that if you put the person on monotherapy and you reassess over time and it's not working, yes, you can escalate the treatment, okay? And that's part of the things that we want to emphasize during this, because the case we discuss is a real-life scenario. Now, so I want us to go through this algorithm, and of course, when we are trying to initiate or escalate treatment of a patient with diabetes, we utilize this, and I think we can be appropriately guided. Now, talking about reducing the risk of hypoglycemia, which this patient unfortunately suffered, there's an option on the poll that said that the risk of hypoglycemia is insignificant because it's just an oral agent. That's totally inaccurate, okay? The risk of sulfonylureas causing hypoglycemia is almost as high as that of insulin, so we should be aware of that. And anytime we are initiating medications, you should consider their hypoglycemia risk, okay? So you have a poor old man that's blind, that stays at home alone, that his meals are not regular, or you know what I mean? So when you are seeing the patient, we'll still talk about the risk factors for hypoglycemia, but that always has to be in your mind when you're starting a patient or when you're escalating the treatment of a patient with diabetes. It should also inform us when we're choosing the medications, and it's always wise to start small and escalate the treatment slowly rather than bombarding the patient with a lot of medications ab initio because you want to impress the patient or you want to get the numbers down. So these are all risk factors for hypoglycemia, old age, frailty, malnutrition, multiple comorbidities. By the time you see them, they have heart failure, they have liver issues. Be careful. Acute illnesses. During acute illnesses, there's a phenomenon we call a stress response or stress hyperglycemia, and it can exaggerate how high the degree of dysglycemia, and it can actually give us a false idea of, and that's why, so in stress hyperglycemia, someone may not even have diabetes at all, and the sugar might go up, and that's one of the things that the A1C can help us to tease out. So liver issues, kidney disease, heart failure, dementia, depression, people that have irregular meals. There's some people like that they just don't eat regularly, okay? Longer duration of diabetes, previous hypoglycemia, people that have hypoglycemia unawareness. Some people are on beta blockers that can blunt the adrenergic response to hypoglycemia, and that can also increase the risk of someone having severe hypoglycemia, because that means the initial symptoms they should experience has already been blunted by medications or otherwise. So alcohol use, sedatives. Some of my colleagues don't even give sedatives to patients that have diabetes or that are medications that have high risk for hypoglycemia. Why? Because someone with hypoglycemia should wake up in the middle of the night because their sugars are going low. They just sleep it off and then they sleep to the other side of the world. It's also important to counsel patients that are being started on diabetic medications on hypoglycemia. So we all owe our patients that duty of care. We should discuss, no matter what treatment you are starting them on, once it's pharmacological, there's a risk for hypoglycemia, we should counsel them on recognizing the early symptoms and the late symptoms, During my residency days, there was a patient that was brought in the middle of the night with fits, okay, and alter sensorium. His sugar was not grossly low. It was in the range of about 85 to 90, okay? But it was being managed already for a stroke and renal impairment because he did have some CKD actually. And it was already being planned for emergency dialysis. CT scan has been ordered. And we just asked that, what was the RBG presentation? They said about 85. And then we repeated it again. It was like maybe 69, 70. But lo and behold, by the time we gave the guy glucose, the guy was fitting, unconscious, drinking saliva, oropharyngeal airway inside too. The guy woke up and started talking within like 30 minutes. So hypoglycemia is very common, and the wife later told us that the guy woke up in the middle of the night and was asking for Coke, and she was like, why should you take Coke? You that you have diabetes, before he slipped into unconsciousness. But that history came later. So not just the patient and the loved ones should be educated about the risk for hypoglycemia and how to manage it, okay? And those patients that are at higher risk, particularly those that are insulin treated, they should monitor importantly, and also they should have something that they can use to rapidly correct hypoglycemia. In the Western world, people carry glucose tablets around. In patients that are on SU, that's sulfonylureas or insulin, they must always have a sugary drink at home so that if anything happens at any time, at the early stages, they can correct it before it gets into the more severe states. So, and of course, after hypoglycemic episodes, even mild versions, because most patients that have severe hypoglycemia have had mild hypoglycemic episodes before. Patients should be taught to analyze the events that led to it. Did I take more medications than usual? Did I not complete my meal? Did I have vomit, or did I have diarrhea that makes sure that the food I ate was not absorbed? Or did I exercise more than usual? So these things are the things that can trigger episodes of hypoglycemia in a patient. So I think that's a summary of the first case, and I hope that the lessons there are well learned for us. So I think I'll let Dr. Obi take us through a second case now.
Okay. For the second case, these are the learning points we are meant to take home at the end of this case. So we have Mr. Kande, a 58-year-old civil servant who was diagnosed with diabetes 4 years ago. He was placed on metformin and glibenclamide and has been compliant with follow-up for the past 4 years. He presented on account of poor vision in his left eye over the preceding days with floating shadows in his visual field, no previous visual problems. He previously saw well without requiring glasses. His fasting blood glucose at presentation was 142 milligram per DL, and his most recent glycosylated hemoglobin, which was done 9 months ago, was 8.6%. So he was referred to the eye clinic, where he was diagnosed with proliferative diabetic retinopathy in both eyes, but it was worse on the left. The eye service then referred him to the specialist diabetes care to optimize his glycemic control. He was also scheduled for intervention, which were laser photocoagulation and vascular endothelial growth factor therapy. He was given a 2-month hospital appointment for the endocrinology review in a general hospital, but before the appointment could come up, he developed sudden onset chest pain and shortness of breath 2 weeks later. He was then rushed to the emergency room, and the diagnosis of myocardial infarction, the ST elevated type, was made, and he required acute care and hospitalization. He made some recovery, but he continued to have heart failure symptoms, and he completely lost vision on his left eye. So from what we've heard, we'll go at what can we learn from this case?
So any thoughts on lessons from this case? Lessons from this case. So you have someone with diabetes that's had diabetes for a while. He was actually going for follow-up with his doctor, so he did his part, apparently. He developed some high symptoms, and then he was referred to high service. Some treatments were planned. He was meant to have some other appointments, but even before the last appointment, he suffered an MI, which damaged his heart quite significantly. And to add salt and pepper to his injury, he lost the vision as well in the eye. So what do you think we can learn from this case? Any thoughts from anybody? Lessons? Yes, please. There's a gentleman at the middle raising a hand. Just lessons from this case. Where is the microphone handler? Microphone. I think there's something else. Backslide.
Thank you. From this case, there were some pertinent points to note. One of them would have been the poor glycemic control. As signified by the HbA1c level, which was above target, his medication should have been intensified. His antidiabetic medication should have been intensified. And also, the physician in charge of his care should have given him adequate counseling on the symptoms that he should have been looking out for worsening of his symptoms, that is increasing severity, as well as he should have scheduled regular follow-ups in order to determine the response to his care. Thank you.
Thank you so much for those answers. I think they were very spot on. So I think those lessons they highlighted and some other lessons we'll talk about as we progress with the case scenario and this discussion. So I think it's very important to know that diabetes has widespread complications. I think we all know that. Thorough systemic evaluation is mandatory. I think we all know that, even though sometimes we falter in requesting for all the investigations, in doing all the clinical evaluation we should do in terms of question, examination, and investigations. Sometimes we falter because of our busy clinics, but we cannot afford that. And in very busy clinics, checklists can be helpful to make sure that this patient has had this check per this time. And the things that we should evaluate includes diet, physical activity, adherence to treatment, impact of work on life, how the patient is coping and what the patient does, routine evaluation for microvascular complication, addressing cardiovascular risk factors, and we should routinely assess for macrovascular complications as well. So we know this already, but sometimes we don't do them quite enough. We should ask for symptoms of neuropathy and check for signs in all our patients, okay? We should look for features of nephropathy in all our patients. We should look for features of retinopathy in all our patients. Importantly, in that case, like I tell our patients most times, is that by the time you have the feature, previous slide please, by the time we have the features of, by the time retinopathy starts to have symptoms, the cat has left the cage, or whatever term they use for that, it's way too late, okay? It's better treated and responds better to treatment before symptoms, and that's why it is recommended that people with diabetes should have their eyes checked annually. Now, we don't do that enough. And from some researches we did, and that they did in UK as well, every other year will suffice for most people, in which the high examination was normal. But anything less than that is totally unacceptable, okay? And the number of people, now diabetes, loss of vision is one of the most feared complications of diabetes. And unfortunately, it is highly preventable. Now, you may not be able to entirely reduce the risk of a heart attack or a stroke in someone with diabetes, totally mitigate. But the microvascular complications actually respond very well to glycemic control, and particularly retinopathy responds early to those measures that they take, the photocoagulation, anti-VEGF therapy, and all of those things. And so I think we should take time to assess for these things in our patients. And I want to highlight the cardiovascular issues here as well. We can see that this patient had poor glycemic control, had some microvascular complications as a retinopathy already, but I'm not sure that the due deed was done. Can anyone remember the blood pressure of that patient? The blood pressure was not stated, and it probably was not checked in clinic. And sometimes when a patient comes with the symptoms that appear to bother them the most, we forget our own agenda, okay? So we should pay attention to cardiovascular risk factors in patients with diabetes. And even if the guy is complaining of serious burning sensation in the foot, he just wants it treated, and then because of that, you just attended to that. You left the cholesterol profile, you left the urinalysis, you left the blood pressure. This is what we get. Okay, so we should see that the cause of death in patients with type 2 diabetes is almost like a global meta-analysis. Sudden cardiac death is up to 30%, heart failure, presumed cardiovascular death. So that's intense, and because of this, we should pay attention to cardiovascular issues in them. So again, over half of the deaths in diabetes patients are due to cardiovascular disease, and that's, I want to hope that we know that traditional treatment for just glycemia alone does not address the cardiovascular risk or the macrovascular risk. And the risk of stroke and a heart attack is increased by 2 to 4 times. And we have our role in mitigating this risk as well. So these are cardiovascular risk factors that I'm sure that we are all aware of, and it is important that we identify them and manage them such that we are seeing less of the coronary artery disease, less stroke, less peripheral arterial disease, less heart failure, etc., and less sudden cardiac death as well. So how can we manage this cardiovascular risk in our diabetic patients? It goes back to the basics. There's nothing highfalutin that's required, really. Measure the BP at every visit. Treat the BP to target. Preferably include a RAS blocker. We should manage lipids in an evidence-based manner. All this, someone that has severe dyslipidemia that you treat with atorvastatin for 1 month to bring down the cholesterol quite nicely, but immediately you stop it, check it 2 weeks or 3 weeks or 4 weeks after, it's back to where it's coming from. So most of them that require those kind of interventions require it long-term. They're not short-term interventions. Smoking cessation, some of us don't ask, regular exercise and weight controls, and then we should assess other cardiovascular risk factors and make sure that we manage them well. And of course, patient education remains very critical. So that patient that had retinopathy issues and ended up having an MI on top of it, the BP was not checked, the cholesterol was not checked. I know that these were not checked because, at least it was not checked recently and was not managed because, as I said, this is a real patient. And so those things add up to the cardiovascular risk, and it will cause our patients to end up like this, which we don't want. So we have a third case here, which I think let's just take briefly.
Okay. These are the learning objectives we want to take home at the end of this case. So Mr. Waza, a 49-year-old banker who was diagnosed with diabetes 10 years ago. He presented an account of painful sensation in both feet that has been ongoing for a few months, but he came now because it has been worsening. He reports being on metformin and vidagliptin for his diabetes, and he has no history of hypertension. So for this case, how would you proceed? So our poll is up. If we can just log in our poll so that we can get our answers and go.
So we have 5 options there. What do you think is the most appropriate, maybe initial step, so to say? Scroll today.
Okay. So, still coming in.
Okay, so thank you so much for the answers. I think we chose the right answers mostly.
Yes.
It's important to examine the feet. It's important to reassess cardiometabolic control. And there's a study that some of my chiefs did in those days that we found out that overall cardiometabolic risk factors correlates with peripheral neuropathic symptoms and signs more than just glycemic control alone. So putting things like hypertension, dyslipidemia, and other metabolic parameters, it carries more weight than that. So there's not so much time for us to go through this, but I think the most important thing I want to tell us on these slides is that, number one, pre-diabetes is associated with neuropathic symptoms. So the nerves are extremely very sensitive to glucose elevation, so that's one. So patients with pre-diabetes can have features of peripheral neuropathy, that's one. Secondly, is that apart from poor glycemic control, glycemic fluctuations, either going up or coming down, particularly fluctuations, is very disruption to the nerve activities and can make neuropathic symptoms to be very worse. So that's secondly. Of course, we have various types of neuropathic symptoms, the most common of which is the first one, that's a distal symmetric one, which we are all familiar with. And we can have all sorts of symptoms and signs, which we should try to elicit in our patient. Don't forget that the patient will not always report these things to you spontaneously. We should look for it. It's important to know that diabetic neuropathy is the biggest risk factor for diabetic foot ulceration and biggest risk factor for foot amputation amongst patients with diabetes. So it's important we look for these symptoms, we look for the signs, and when we pick them, we should address them as appropriate. And of course, this is the approach So we should clarify the symptoms, we should examine appropriately, we should look at other long-term complications, because these complications don't work alone, they come with other guys. We should try to optimize the patient's cardiometabolic control. Don't forget that when you give the neuropathic analgesics like gabapentin and pregabalin, it just treats the symptoms, it's not treating the drivers. So we need to address the drivers, and then you need to explore other treatment options that you have. These are common differential diagnoses of the neuropathic symptoms in diabetes. Importantly is vascular claudication, which people often mistake with that. So I'll focus on that vascular claudication a bit. Classically, diabetic peripheral neuropathic symptoms is worse at rests. Okay, so the patient feels it's worst when they lie down in the night or when they just get out of bed in the morning. That's when they feel it the most. But by the time the patient tells you that they have pain in their feet or their legs, that it's worse when they are walking. You're probably more likely to be dealing with vascular claudication, or if it's neurological, then it can be neurogenic claudication. So vascular claudication can look like this. The level of discomfort depends on the level of occlusion, but importantly, it's typically worse with exertion. The patients, sometimes it can be worse at night as well in patients that have rest pain, but that's usually at the very end of it. So when you elevate the leg on the bed, that's vascular supply is a bit further diminished, okay, but classically it's worse on exertion. We should examine the feet in patients with suspected peripheral neuropathy. It's important, and I know that most doctors, most of us don't examine our patients' feet, and I want us to do better in that regard so that we can mitigate the risk that comes along with this. Once again, once you see a complication, once you see microvascular complications, look for the other microvascular complications and also look for macrovascular complications. In this man that had a heart attack, once again, if a thorough evaluation has been done at the time he developed retinopathy, maybe that heart attack could have been prevented. Maybe someone will have seen something on the ECG and put this person on a aspirin, for example, if there were ischemic changes. Or maybe someone will have done the lipid profile and saw that the lipids is not a target and put the person on a statin. Maybe the blood pressure will have been checked and they will have been kind enough to put the person on an ARB or an ACE inhibitor. So this is how to optimize cardiometabolic control again. We are aware of all of these, so I don't think there's any other point I need to emphasize here. And of course, if the symptoms are atypical, just like the symptoms suggesting vascular claudication, please get help. Discuss with a specialist, discuss with a colleague so that we can all be pointed in the right direction. So this is about that man now. The blood pressure was high. The total cholesterol was very high, even though the kidney function was good. We already mentioned the A1C, which was reasonable. Okay, the glucose readings fluctuated. Okay, and I did mention earlier that fluctuations in glucose is quite very bad for neuropathic symptoms. Of course, there was sensory loss to both monofilament and vibration sensation. So this is the way the patient was managed. A dietitian review, diabetes treatment was optimized. It was placed on the DASH approach for hypertension with a plan to commence medication if the BP was not at target within 3 months. It will also be appropriate to start this patient on medication immediately if he chose to, actually. Starting for dyslipidemia, foot care counseling, book for foot cleaning. Don't forget that patients who have symptoms plus or minus signs of peripheral neuropathy have a high risk for foot ulceration. And that means foot counseling is very, very, very important for those patients. Otherwise, they'll come to your foot clinic next month with a foot ulcer, and they'll tell you that they were using hot water or they put the foot on a lantern because it was aching there. And I'm sure we've seen all of those kind of patients before. Or they call someone to come and massage it for them or do something strange, and then the foot will just be all bad. Unfortunately, I have maybe about 2 or 3 on the world currently, which is quite disheartening. One of the ones we have on the world currently was managed for the foot ulceration maybe 4 months ago or 6 months ago. It got better. It was superficial at that time. She went to the village, and then some things happened, and some things happened, and some things happened, and then she's back with another one. Okay, so that's that case. I think we'll take a 4th case, which will be the last one. Try to be fast with this.
Okay, for this case, these are the learning points we need to take home at the end of this case. So for case 4, we have Miss Juliet, a 33-year-old teacher that first presented with marked weight loss, blood vision, and paresthesia in both feet. She was diagnosed with diabetes 6 years earlier on, and her medications were metformin and sitagliptin, which she took as prescribed, but still yet her blood glucose remained uncontrolled, with fasting blood glucose mostly around 20 millimoles, and she believed her medications were not working for her. On presentation, she was noticed to be chronically ill-looking, afebrile, not pale, mildly dehydrated, aneuric with no pedal edema. Her pulse rate was 90 beats per minute regular, and her BP was 105 over 75 millimeters of mercury. Her weight at presentation was 56 kg with a BMI of 18.9. Fasting blood glucose done was 286, and an urgent RBG was 394 milligram per DL. So for this, how we proceed? The poll is up. So which of the following is preferred? How will you proceed for this patient? Please let's go online and log in our answers.
Do you want to just optimize our diet and reassess in 3 months? Do you want to add a sulfonylurea? Do you want to add glimepiride? Do you want to add a GLP-1 agonist? Or you want to refer for specialist assessment? How old is she again? 33 years old, right?
Yes, 33 years old.
33-year-old woman that does have diabetes for a
For
while,
6 years.
quite a bit, and then on medications, but the glucose was still quite high. How often do we see this kind of patients that have been on oral agents, but the glucose is still really high? Not just marginally high, but still really high.
Okay. So from the poll, a lot of people...
Okay, so I think, again, we are choosing the right answers, which is good.
Yeah.
The patient should be admitted for rehydration. Patient should be sent for specialist assessment.
Okay.
The assessment is probably a preferred answer for me because rehydration alone will not solve the problem. If you rehydrate the patient and you leave the patient still on that same medication, you've not really done so much good. The rehydration you rehydrated, patient you urinate it hopefully within the next 24 hours. So that's not, so the treatment actually needs to be reassessed, okay? So in this patient, I think you continue.
Yeah, these are the initial evaluation that was done for the patients, the investigation, full blood count, electrolyte, urine creatinine, malaria, urinalysis, a glycosylated hemoglobin, and lipid profile. The urinalysis came out to show glucose of 3+ with a full blood count showing relative neutrophilia.
Okay, so the rest of the results is as shown on the screen. So what do we think the diagnosis is? What do we think the next step should be? No, let them see it very well. Okay, so I think one of the key points we want to highlight with this case is monitoring of treatment. Monitoring of treatment. So I've seen patients a lot that will tell you that they will prescribe this medication in 2020 and they've been using it. Do you check your sugars? No. So how do you know it's working? Well, I take my drugs. Well, that's not enough. You need to know that it's working. And monitoring treatment is important, okay? You want to monitor to assess the response. And you should not assume that just because someone is getting medication or getting treatment, that then that means the treatment must be working. No. It's important to monitor rightly. So we have patients that monitor too much, and then some monitor too little. The amount of monitoring we do should be based on these things I wrote here: intensity of the treatment, risk of hypo, whether there is complications already, whether you recently escalated medication. And the monitoring frequency is as written here as well. So some people can need low monitoring, but some needs quite high frequency of monitoring. But beyond monitoring, it's important to understand, interpret, and act on the data. Okay, and I have a lot of patients that don't do that, even a lot of doctors that don't do that. And what I tell my patients is that it's like you employ a security man to sit outside to be checking for armed robbers, and they see armed robbers coming, and went back to sit down. He look out again, see that the armed robbers are closer to the house, then went back to sit down. So why are you checking? What's the point in checking if you're not going to act on it? And you can see that woman has been getting fasting in the range of 20 millimoles per liter, and then they're still doing the same thing. So that's futile monitoring, so to say. So it's important that we act on it, and then we don't let any monitoring go to waste. So we should do the A1C routinely for our patients at this frequency, usually at 3 to 6 months, and target to be individualized, typically less than 7% for most patients. And if targets are not being met, particularly within up to a 6-month period, you need to escalate care. We should not continue what we can see that is not working. And it's important to educate our patients about targets as well, because patients that are well educated, once you've told them the targeting is not being met, even if you as a doctor don't do the right thing, they'll say, but doctor, this thing is high now, okay? So if targets are not being met, what should we do? These are what we should do. Cross-check the diet, weight control, physical activity, make sure the patient is using the medication and following the treatments as agreed, reassess the drugs you're giving the patient. Is this an appropriate combination? reassess the type of diabetes. And then, of course, in type 2 diabetes, you should consider whether there is beta cell failure. We do know that more than half of patients with type 2 diabetes will have beta cell failure and begin to require insulin after about 7 years of diagnosis. That's from pool studies, okay? And of course, if targets are not being met within 6 months of care, we need to escalate and let a specialist say. Don't allow patients to fool us that, doctor, don't worry, let me just work on my diet and my exercise. For gross glycemic gaps, what I mean by gross glycemic gaps, I'm talking of A1C that is really above target. So I'm not talking of someone that is getting 7.4 or 7.8, in which, you understand what I mean, Abi? That what you need to get down is not much. But someone's having A1C of 9.2. What dietary change do you want to change that will bring 9.2 to 7? There's nothing you're going to do in that regard. So, and we should realize that diet and exercise will never get to ideal. I'm not sure if anybody does ideal, whose diet is ideal, that is perfect, 100% here. No. So don't let patients keep pushing you, because they do that a lot, okay? And by saying that, doctor, let me work on my diet, they say for like 3 or 4 years until the kidneys are gone, and then we're now running helter-skelter. So that's important. It's important to recognize that even though type 2 diabetes accounts for more than 95% of diabetes, there are still other types of diabetes. There are other types of diabetes, okay? And because diabetes is a very common condition, some of them will be the other types, okay? It's important to also know that about 10% of people that are diagnosed with type 2 diabetes are actually what we call LADA, that's latent autoimmune diabetes of adults. So like a type 1 diabetes, but it's a slow, smoldering kind of type 1 diabetes, such that the beta cell damage and failure takes place over years rather than days to weeks of the classic type 1 or autoimmune type 1 diabetes. We should also be able to recognize hyperglycemic crisis, which was one of the lessons for this case. I'm not sure, it wasn't part of the poll, but do we think that the case we presented is an hyperglycemic crisis or not? Okay, so she had glucose that was quite high. I think it was in the range of 300 or something like that. Okay, but the patient was otherwise largely fine, just mildly dehydrated. So in HHS, which is one of the common hyperglycemic crises, so we have 2 common types of hyperglycemic crisis. We all know that already. So, but when we see patients present with diabetes, presenting with patients with diabetes or patients with hyperglycemia, presenting with acute illness, significant hyperglycemia greater than 250, or acute metabolic derangement, that's talking about maybe creatinine a bit high, urea high, or metabolic acidosis most importantly, you should ask yourself whether you're dealing with an hyperglycemic crisis, and it is often missed. I will tell you that. It is often missed, okay? So we have criteria for HHS as hyperglycemic hyposmolar state, and these are the 3 cardinal things you tend to see there. That's usually a profound degree of dehydration. Patient is usually very dry. Marked hyperglycemia, typically greater than 600. Raised serum osmolarity, which you can calculate using the formula below here. Okay, the other typical things we see in HHS is illness, typically over several days to week. Typically older patients, it's uncommon in young patients. And then metabolic acidosis is usually not prominent. Ketosis or ketonuria are usually not prominent either. Okay, compared to DKA here, in which you usually tend to have a more milder or moderate degree of dysglycemia. Metabolic acidosis is a must in DKA. Acidosis is central to the name of the diagnosis. You tend to see ketonemia, and then typically it's more of an acute illness, typically a younger patient. Typically there's hypovolemia, which is usually less marked than what you see in HHS. Okay, and then more common in patients with type 1 diabetes generally, but in reality, because type 2 diabetes is more than 95%. So most of the decay we see here is still more in type 2 diabetes. And of course, if you calculate the anion gap, it will be high. So anytime you see a patient with hyperglycemia, blood glucose above 250, you need to ask yourself whether it meets the criteria for a hyperglycemic crisis or not. Of course, there's what we call the euglycemic decay, but I won't want us to go into that at all. So of course, there are other hyperglycemic states, uncomplicated hyperglycemia, or hyperglycemia with other acute illnesses. So someone comes with sepsis and then there is hyperglycemia. So an hyperglycemic crisis itself, okay, but you need to pay special attention to that. So now I'll go back to this patient we discussed as we're rounding up. You can see that the patient is a young patient, 33-year-old, diagnosed 6 years ago. That means he was diagnosed in her late 20s, okay? Failure of oral glucose-lowering agents. There are clinical symptoms, typical diabetes symptoms. The patient was not specifically acutely ill. The examination findings, patient was not overweight or obese, which are classical or typical things we see in type 2 diabetes. Was only mildly dehydrated. Vital signs were unremarkable. And of course, we have this investigation results, okay? So, given that, do we think the patient has HHS or DKA? Who has any thoughts on that? Do we think the patient has hyperglycemic, hyperosmolar state, or diabetes ketoacidosis? Any thought? Any thought? Any thought? Neither. So someone says neither. So I agree with that. So the patient does not have either of. The patient does not have an hyperglycemic crisis. Okay, but the patient has just severe hyperglycemia, poorly controlled diabetes, malaria test positive, and no ongoing infection was identified. The corrected sodium, we should know that hyperglycemia can give us what we call pseudo-hyponatremia. Okay, just due to the osmotic changes, pulling some water into the extracellular tissue that would dilute the sodium, and so the corrected sodium was not so bad. Okay, and the background diabetes type was thought to be ladder. She fits the profile for latent autoimmune diabetes of adults, and clearly the oral agents were not working. And of course, we did a GAD65 antibody test in a patient, which is available. It typically comes out in about a week or so, which confirms the diagnosis of LADA, that's ladder diabetes. And of course, she was still admitted for inpatient care. Sorry, the result came out after treatment or after this acute admission. Admitted, some rehydration like people picked, blood glucose was managed, and of course, she was converted to insulin, and her glycemic control has been excellent since then. Of course, patients are typically happier. Unfortunately, patients that are poorly controlled on inappropriate treatment, typically they tend to starve themselves. I'm not sure whether you've seen such patients. The doctor, even when I eat cucumber, my sugar will go up, and then they'll be frustrated. They tend not to eat, their lives are miserable, but with right treatment, the patient is able to go back to a normal diet. Now, when I say normal diet, I don't mean an unhealthy diet, but a normal, balanced, healthy diet that everybody should be able to eat. And usually, of course, they're grateful for it. So I think these are some of the learning points we've picked today. I won't go through them. Thank you very much.
Thank you very much.
Any burning questions? Any questions? Any questions? I'm not sure we asked any during the course of the presentation.
Okay. Thank you very much. Your experience, I don't know whether you've had cases that you would say are in remission. You know, like you have patients, you started them on treatment, and with time, you've downgraded the treatment to the basal level. At what point would you take them off that treatment, or is it treatment for life?
Thank you very much for that question. I think that is a theme that is on many people's mind, actually. So yes, diabetes mellitus can technically be in remission, but the remission, or the so-called remission, is a technical term. It's purely a technical term. So treatment of diabetes mellitus is generally lifelong. Now, the medications are not lifelong, okay? And we know that treatment can continuously be escalated or de-escalated. So we have patients that from onset of treatment, they lose 5 kg, they lose 10 kg, they don't require medication again, and then they continue to be fine. They can be fine for years, okay? We can technically call that remission, okay? But that lifestyle treatment, that physical activity, that dietary changes is still a form of treatment that they continue. And that's why I refer to that remission as a technical term. But yes, that is actually very common. So if you have a patient that weighs maybe 110 kg today now, and the patient has diabetes, maybe fasting in the range of about 154 or 160, it was around 8 or so. If you start medication now, which is fine, the patient is able to lose 10 or 15 kg, the person will not require medication again, actually, okay? But we all know the issues with lifestyle modification. Patients find it difficult to sustain, abi? Yes. And of course, unfortunately, again, diabetes is a progressive disorder, and that means that the incompetence of the body in handling glucose and other nutrients is something that continues to evolve and generally gets worse over the years. Beta cells apoptosis continues to worsen over the years. So even if that graph is common, basically. So the person actually gets better, stop requiring medications, then several years later. But the key thing is to keep monitoring. So yes, we do stop patients' medication sometimes, particularly if someone that was diagnosed early and was able to do a lot of lifestyle interventions to mop up a lot of the issues. Thank you very much for the question, sir.
Thank you very much for your presentation. Please, I would like to ask about what is the current, in current clinical practice, what is the place of Dalnil in the oral management of diabetes? Thank you.
So thank you for the question. That's glibenclamide still has a role in the management of diabetes. As much as possible, the Western world is shying away from use of sulfonylureas, and that's totally appropriate because of the issues. A lot of us prefer glimepiride to glibenclamide, okay, but they're both sulfonylureas. Okay, but it still has a lot of role in developing countries like ours. It's cost efficacious. Don't let me say cost efficacious. It's cheap. It's accessible. So those are the main points. Okay, but metformin will give you a better bargain. The other agents, SGLT2 inhibitors, DP4 inhibitors. So all of those guys are things that we should prioritize instead of sulfonylureas. But of course, cost often pushes us back to the sulfonylureas, and their role in the management of diabetes in this part of the world cannot be denied, and it's going to remain so for the next several years, really. So it still has a very strong role. Thank you very much.
Okay, thanks again. For type 2 diabetes, who have a risk factor of diabetes, either grade 3 or 4, with poor glycemic control, I wanted to know your experience with use of GLP-1 agents, either the injectables, Ozempic, or the tablets, Ribelsus, if you have any experience to share. Thank you.
Sorry, I didn't get the question very well. For people with diabetes that have what?
Glycemic control with obesity, either grade 3 or grade 4.
Grade 4 what?
Obesity.
Oh, obesity. Thank you very much. So the truth is that the GLP-1 agonists they are very good medications. They're excellent medications. So I've had experience with them, and it helps with weight loss. Now, the amount of weight loss the amount of glycemic control you get, and the amount of weight loss you attain is quite variable within individuals. But yes, I've seen some quite, I won't say dramatic, but quite remarkable weight loss with it. Unfortunately, the weight loss is only sustained as long as the person can sustain using the medications. And unfortunately, many people are unable to sustain the medication. So it does well with both of that. And additionally, we know that it has benefits in reducing cardiovascular risk, particularly risk of stroke and MI and all of that. So yes, it works very well in that regard. And there are some weekly ones now that just requires to be used once a week, but the price tag is still very hefty for now, unfortunately. Hopefully, over the next few years, we might be having some biosimilars in that regard that might be more affordable to the regular Nigerian. Thank you very much.
Okay. Thank you very much. Once again, I'll be referring to the multidisciplinary team. Since you've mentioned that there was a lot of improvements with patients who had undergone, let's say, weight reduction, management of obesity or something like that, and also nutrition or dietary changes. Now, how do you as a member of the multidisciplinary team, because it's easy to say that patients are not going to adhere to these things. They're not going to adhere to the advice to work out or to watch their weight or manage their diet and all that. So how do you ensure as a member of the multidisciplinary team to get other key players involved? Definitely the exercise expert, probably an exercise physiologist or a physiotherapist, is meant to be a member of the team managing a patient with diabetes, the nutritionist and all. So how do you get them to actually be very involved in this management? I actually came across a study that was looking at the role of these, different combinations in management of patients with diabetes type 2 specifically, and reported reversal of that, type 2 diabetes. And that was a combination I saw like 3 different studies: bariatric surgery, physical activity and exercise, and then nutrition. And I saw another one basically talking about just physical activity, nutrition, and medications. So that quite fascinated me, and I wanted to throw the question: how do you get other members of the team involved? Thank you.
Like you rightly said, multidisciplinary care is the name of the game. Now, in terms of getting patients to do regular physical activity, most people don't actually require a personal trainer or anything to do regular physical activity. It's just human nature to start well and then decline. So just general encouragement in clinic and things like that. Now, there are specific patients that require support from the physical therapy team. And those patients are very common, so you can have patients who have osteoarthritis. They'll tell you that I cannot walk if I try to walk, and then they require specific exercise. So some people have musculoskeletal limitations, and then people with gross obesity will require that as well. Some places have gym or gym, spa, or other memberships as things to be an incentive for patients to do. Okay, but I don't think anything particularly beats the physician in the office encouraging and reminding the patients each and every time to follow up on other components of the treatment, particularly the lifestyle part. And usually I tell patients that that's the most difficult part to do in a sustained way. But again, like you rightly said, multidisciplinary care is the way to go with the dietitians, people that require a personal trainer or specific requirements for the exercise, which is common again. People that are very obese. I have a lot of people who have severe arthritis, and then they have pain in the back when they do this, and those have to see a physiotherapist to guide them in what they can do. Some is swimming, or cycling, or some other specific. So we should identify those kind of patients, and those are the patients that really, really struggle to get enough physical activity. So thank you for that question, and it highlights the role of the MDT.
Thank you, Chief, for that wonderful presentation. Are we tired? Our brains are tired, right? I can see smoke coming up from our heads. Now imagine you have to do this every morning. Okay, so we are fast behind time. On the agenda, what we have is the lunch break, but we will not be breaking. We'll be having lunch where we are seated without much fanfare. And we'll be moving